The next symposium explores integrated strategies for chronic disease management under the theme Enhancing NCD Care Across the Continuum. I cordially invite Professor Chamila Methananda and Dr. KVC Janaka to chair the session.
Good afternoon. The next symposium is on enhancing NCD care across the continuum. We'll be having 3 lectures. The first lecture is on individualizing glycemic goals and therapy in type 2 diabetes by Professor Tilak Veeraratne, MBBS, MD, FCCP, FRCP, FACP.
Good afternoon and thank you for your presence. Sorry about making a small change in the title slide. Goals have become targets because I am not a football player, I am a marksman. So, welcome to this session on individualizing glycemic targets and therapy in type 2 diabetes. During the next 20 minutes, I'll be talking to you to give a review for the rationale for advocating individualized glycemic targets and therapy for patients with type 2 diabetes. In doing so, I will take you through 5 of these subtopics just to find an answer why you should individualize glycemic targets and therapy for patients, and how the shift of guidelines from one size fits all became individualized therapy, and what parameters matter in the individualization of glycemic targets and therapy, and finally, to sum up with case scenarios and forecasting the future through the available evidence. I think all of you will agree with me. Among the many things that we know about type 2 diabetes, the most fascinating things about it to me is its heterogeneity. Even though we call it a one disease entity, it is widely heterogeneous. Attempts have been made to classify diabetes in the past. From type 1 to type 2 is the currently available classification. But we do know within this type 2, there's some type 1-like behaving, what sometimes called 1.5. But outside this type 2 also there are some guys like Modis and all. So we don't know much about this heterogeneity. To answer this question, some researchers in the West have used a cluster classification, a clustering by selecting few major clinical and biochemical parameters, age, BMI, HbA1c, GAD antibody level, insulin resistance indices, and following them up and try to come up with a better understanding of this heterogeneity. And they came up with these 5 types of type 2 diabetes, all different from each other, so heterogeneous. So they seem like SED, SID, MOD, SERD and MAD. I'll tell you what these mean. They are not code names of a World War III or something, but they are useful for the application of and prediction of outcomes. That's what matters, we the clinicians, how we can predict this particular patient with diabetes might end up with early insulin requirement, and this patient might end up with early nephropathy, and that is what we as clinicians would know, and that is why this individualization is required. So this is what SED, SID, SERD, MOD, MAD means. Severe autoimmune diabetes, severe insulin-dependent diabetes, severe insulin resistant diabetes, mild insulin resistant with mild obesity related diabetes, mild adult related diabetes. So these are the 5 types within the so-called type 2 diabetes that we come across nowadays. The SED is early onset, lean, they have poor metabolic control from the beginning, they are insulin deficient and they are GAD positive. The SID, they have all the characteristics other than the GAD being negative. SIRD, they are insulin resistant but they are obese. But mind you, there are so many patients obese who are metabolically healthy. There's a category of obese who are metabolically healthy. But I used to call them, you are metabolically healthy but you are mechanically unhealthy, because what they develop is arthritis and so on and so forth, and then get the MARD. So these are the 5 major types. So if you can identify these 5 types and give individualized therapy for these, hopefully we can expect better clinical outcomes. So the parameters used so far are the age at diagnosis or age at onset. I would call it age at diagnosis. We do not know really the onset was, it's at the diagnosis. The onset may have been really in utero. The BMI and the pathophysiology, IRO, IS. But these are the conventional parameters. With the advent of or the transformation of the glucose lowering guidelines over the last 3 decades, what you notice here, don't worry that you don't have to go through each and every letter because this is a crowded slide. Way back in 2000, we initiated all patients with type 2 diabetes, metformin, unless otherwise contraindicated though. But come 2025, we don't do that. The advocation is not that. You decide the first line therapy based on the comorbidity, whether you have established ACVD, whether you have a heart failure, whether you have some form of renal impairment. Then you have a specific therapy which is proven to reduce the progression or proven to reduce the mortality due to that particular disease. That's where the one-size-fits-all hypothesis has been changed with the addition of comorbidities and complications at the diagnosis. Therefore, with this approach, we clinicians have 5 phenotypes that was described in the cluster analysis by the researchers about 3 years ago. Even though it has not been come into guidelines as such, but as clinicians treating diabetes patients, we know these clusters do exist in the widely heterogeneous group of type 2 diabetes. So this heterogeneous group, young, old, thin, obese, insulin resistant, insulin deficient, they need individualized care. If you treat them all alike, that's what we have been doing all this time. That's what we have not been able to show a drastic reduction in the mortality of patients with diabetes. Even though we can boast about advances in diabetes and treatment and so on and so forth, the fact is that the cardiovascular deaths due to diabetes, progression into renal disease due to diabetes, haven't been changed significantly over the past, at least up to a decade ago. Now we are seeing some change with the individualized approach. So the first part of this lecture is mainly on the glycemic targets. I'll talk about glycemic therapy in the next part. Individualizing glycemic targets in type 2 diabetes. We do know that glycemic status is currently measured not by just fasting blood glucose, by the glycated hemoglobin, and also not again by the home blood glucose monitoring alone, but we in Sri Lanka also now can boast that we do have continuous glucose monitoring in our country, at least in the private sector. So in that continuous glucose monitoring, which I will elaborate more in the next slide, we talk about time in range, we talk about time above range, and we talk about time below range. That's important for the patients to understand that you cannot be in one particular blood glucose level every time, because that's one of the main questions bothering them. Doctor, yesterday it was 110, today is 115. Why is this? And so it's a range, and you can go up and down within this range. So you don't have to go through the how frequently HbA1c is that, but just to make sure that the recommendation is at least 2 times a year. Even the newer guidelines on ADA says if the patient's HbA1c is stable, that is really relevant to a country like ours where the HbA1c test is quite expensive. But if the circumstances demand, it may be checked frequently than that. This slide summarizes the metrics of continuous glucose monitoring: ambulatory glucose profile, time in range, time below range, time above range. And to be optimal, we expect time in range to be at least 70% of the time. So 70% of the time is good, because as an academic ISO, we give a distinction when the 7 marks above 70. So if you can keep your time in range within 70% of the time, you are okay. Your HbA1c is going to be good within the optimal level. But for a patients who are high risk of hypoglycemia, if your time below range is more than 50% of the time, that is not good. I'll come to that later. So let's talk about the lessons that we have learned from the landmark clinical trials, controlled trials. You can forget about the DCCT at the top because it's type 1. And the next UKPDS, Accord, Advance, and Verdit. What did it reveal? They revealed that microvascular complications can be reduced, not the CVD significantly. And Accord revealed that mortality is increased. But if you look at the second one with the graphs, that is more important. The UKPDS post-trial monitoring showed us the legacy effect that the early intensive control in younger patients had a benefit even after 2 decades. And the Accord showed us if you try to reduce in an elderly established patient with diabetes blood sugars too much early, too much soon after the diagnosis, you will end up with the high mortality. But Advance showed you can still reduce it, not at the beginning, toward the gradually, then only you get the benefit of glucose lowering in the elderly. So these are the lessons that we have learned. So lessons learned in the history often shapes our future. That's why we now do not go very hard on elderly when they are diagnosed, especially when they have established cardiovascular disease. So individualize based on the characteristics of patients with diabetes, not only the age, not only the BMI, others as well. Now these are the guidelines. A1C less than 7 for otherwise healthy people, but A1C is definitely different in different categories of patients. And A1C is also slightly different among the professional organizations, from ADA to AACE to ESAD. And so this also gives some ideas about the time in range target. More than 70% of the time, there's a high evidence grades for that. And the moderate evidence for older adults, the time in range should be 50%. So 50% times they can be out of range. But if you try to keep them 70% of the time within the range, they will end up with hypoglycemias. That's the lesson. So we'll take the younger patient, low risk. They need tighter target. They need early intensive control. Because we are hoping a legacy effect in about 2 decades of follow-up. Early tight control preserves beta cell function. There was an earlier theory that when the blood sugars are very high at the beginning, you need to give insulin to preserve, because there's a glucose toxicity and beta cell will not respond to secretagogues. You have to get the beta cell to rest and give exogenous insulin. but it is not much taken in the latter studies. And MACE reductions with early control is proven with the post-trial monitoring of UKPDS. For older frail patients with multimorbidity, of course, there are less stringent targets, 7.5 to 8.5, time in range more than 50% only, we don't expect again. And de-intensify. Now here, type 2 diabetes is a progressive disease. You need to keep on increasing, but there comes a time you have to de-intensify. So keep that in mind in managing older, frail patients with multimorbidity. So this slide summarizes, according to the stage of diabetes type 2, how the HbA1c is set, target is set for HbA1c. So I will skip because that I have a 7.5 minutes for the going through the individualizing glycemic therapy. I thought that is more important. So still it is a glucose-centric, but glucose-centric according to the patient's weight, hypoglycemia risk, and other factors. If they are non-obese and all that, you can go into other guidelines or other algorithms. So this is a comorbidity, so complications. This is the newer approach to patients with type 2 diabetes medication algorithm. You go by the complication of comorbidity-centric algorithm. The ACVD, they have a different pathway. If they have a CKD, they have a different pathway. And if they have a high prone to strokes or previous strokes, they have a different pathway and different agents. Let's look at the obesity-centric pathway. If the BMI is still 27 to 29, preferred one ideally is a GLP-1, but in our setup, it will be metformin to start with. And when they are in the range between 30 to 35, like you have the GLP-1 dual and triple, of course, when the BMI is very high, they should go for bariatric surgery because that is known to even cure them of diabetes. When it comes to CKD-centric, early CKD, in the sense the eGFR is between 90 to 60, the first line is SGLT2, along with AC and ARBs. And the moderate, again the first line is SGLT2, and advanced CKD, of course, it's a GLP-1 has a little nod more than the SGLT2. ACD-centric pathway, those with established cardiovascular disease, the main focus, if the heart failure is the main comorbidity, number needed to treat and the absolute risk reduction, SGLT2 comes high in the list, next to the GLP-1s, and you can give combination therapy. You might wonder what happened to metformin, your good old friend. They do have remain the first line OHA for the most patients if they do not have any of those established ACVD, CKD or heart failure or other complications. Role of SGLT2 inhibitors, the drug of the decade. You can see heart failure hospitalization number needed to treat is only 32. CKD progression is a 37. MACE reduction is 83, little high. So the benefit has to be transferred to patients if they have these comorbidities by using. And the clinical trials with high and moderate evidence has been given by the site. GLP-1s, we are starting to get GLP-1 into our Sri Lanka. So better to be aware of its applications, its benefit. Semaglutide has not been entered market, but awaiting soon. So these are the benefits with high evidence from several landmark clinical trials on the MACE outcomes and the CKD outcomes. But still, the things that we routinely use, sulfonylureas, TSDs, DP4, they do have a place in a particular patient, especially in the low resource or restrained resource setting. Now, this slide summarizes a lot. When it comes to MACE reduction, how the newer agents perform. When it comes to heart failure hospitalization, you can see the glitazones have been harmful. When it comes to CKD progression and all-cause mortality, how still SGLT2 inhibitors occupy the hot seat. So these are the few cases that he's a newly diagnosed obese patient with no complications. His target has to be less than 7, target in range in the continuous glucose monitoring. So in our setting, it is a metformin, but better if you can use GLP-1. But we expect the weight reduction, that's why GLP-1 will do better, and monitoring with the liver enzymes later on if you are still on GLP-1s. Second patient with established diabetes with a renal involvement with albuminuria significant. His again the primary therapy is SGLT2/1, but with the addition of GLP agonist later. A patient with a multimorbidity and polypharmacy. What matters here is not the target being less than 7. It has to be 7.5 to 8.5. Target in range has to be more than 50, not more than 70. And you have to think about the de-intensifying. So what are the future directions? Future directions are MASH is going to be more and more prevalent among diabetes. So I have to think about the drugs which is known to reduce MASH. Cognitive protection, because the patient's life expectancy is getting higher. Dementia is getting more problem. So you have to think about drugs which has effects on cognition. So dual therapies and sarcopenia prevention. With elderly being more in the society, less active, sarcopenia becoming a problem. So when you give medications, that also has to be seen. Now precision medicine, we are in an era where we learn medicine through anatomy, biochemistry, physiology. But in another couple of decades' time, it will be precision medicine, where they will learn medicine with genomics, proteomics, metabolomics, transcriptomics, and so on and so forth. So anatomy, biochemistry hopefully will be replaced by this mix. And they will identify patients' genotype, their response to therapies, and AI will help us to direct which therapy to be used in which patient. So that is precision medicine. So this is how the 5 subtypes of patients with type 2 diabetes are treated, should be treated. If you use individualized approach from the SED, SID and all, they are not treated all with metformin, all with sulfonylurea, all with SGLT2 inhibitors. So individualized therapy should go beyond medications. Adherence, access and cost strategies has to be borne in mind. And diabetes distress is something that you need to worry about, you as a caregiver as well. So this is a 10-point practice checklist list. Initial assessment, risk stratify, establish individualized therapy, identify the phenotype, it is a SID-SED. Even if you do not name it, at least keep that in mind. This patient is very likely to be insulin deficient one. This is going to be insulin resistant one. Therefore, the particular drug has to be justified. So, sorry about going the last minute. It's a individualized glycemic target based on the patient characteristics and comorbidities and the hypoglycemia risk. And integrate TIR metrics, target in range metrics, along with HbA1c, because we are going to experience continuous glucose monitoring at least in suitable patients. Consider de-intensification. Even though type 2 diabetes is a progressive disease, it does not matter that you have to keep on going up and up and up. Thank you.
Thank you, Professor Veeraratne, for that elaborative lecture.